هاي تحريم خانة دي من حكينا وياها هذه تحريم خانة دي تشتغل بي شفتها؟
تعالنا بلادي
هذه من بنغلاديش
شكون ياخذ
حليت لي كمان تبع
Excellencies, ladies and gentlemen, good morning, good afternoon, and good evening. Her Excellency Chair of PPD Board and Honorable Minister of Social Development, Government of South Africa, Madam Lindri Zulu, His Excellency Treasurer of PPD Board and Honorable Chairman of BKKBN Indonesia, Dr. Hasto Wardoyo, Observing Specialist and Consultant, Mr. Arthur Erkin, Honorable Director of Policy and Strategy Division, UNFPA, Mr. Adnan bin Haj Aisa, Executive Director of PPD, Honorable Board Members of PPD, respected PPD Partner Country Coordinators, Honorable Speakers and Research Persons, Development Partners, Universities, Civil Societies, Organizations. I am Tahrima Khan, Senior Program Officer of Partners in Population and Development. First of all, I am pleased to announce that PPD, in collaboration with BKKBN Indonesia and UNFPA, are committed to promote South-South cooperation in reproductive health, population, and development within the framework of ICPD Program of Action and 2030 Agenda of Sustainable Development Goals. It is our great privilege to welcome you all to this webinar on dissemination of best practices from 11 PPD member countries, aiming to create demand among southern countries for reserve linkage to exchange knowledge for replication of best practices and establish a virtual forum for exchanging knowledge among the countries through South-South cooperation. We provide this webinar with simultaneous translation of English to French. Kindly select the button from interpreter tools and set the language as needed. Also, I want to inform you that please write your comments and questions in Slido. We are sharing a link in the chat box. Please click the link and then put your name and country name to share your comments and questions. To begin with, I would like to invite Executive Director of PPD, Mr. Adnan bin Haj Aisa, to deliver his introductory remarks. Mr. Adnan, the floor is yours.
Okay, thank you, Tahrima. Thank you very much. Your Excellency, Ms. Lindri Zulu, Minister for Social Development, Government of South Africa, and Honorable Chair of PPD Board. Your Excellency, Mr. Hasto Wardoyo, Chairperson of National Population and Family Planning Board, Government of Indonesia, and Honorable Treasurer of PPD Board. Mr. Arthur Erkin, Director of Policy and Strategy Division, United Nations Population Fund. Ms. Shuaad Dasuki, Director of Population Policies, League of Arab States. Professor Rizal Damanik, Deputy Director of the National Training and Research Center, BKKBN Indonesia. Honorable PPD Board, respected consultants and discussants, dear participants from all over the world, ladies and gentlemen, thank you so much for joining today's webinar on sharing best practices in the field of reproductive health, family planning, and population. We are proud to organize this important gathering with the technical support from Indonesian Board of Family Planning and Population, BKKBN, and also with the generous contribution from UNFPA. As you may know, one of the key interventions of partners in population and development is the exchange of information and sharing of strategies and approaches with member and non-member countries from the Global South, and which are crucial of cooperation and of the United Nations Office for South-South Cooperation. Learn how applicable to other developing countries. Excellencies, distinguished participants, ladies and gentlemen, there is an urgent need to identify solutions in population and development and reproductive health for countries in the South during and also in post-COVID-19 era. In order to achieve the 2030 Agenda for Sustainable Development and address the COVID-19 impact, it is important for developing countries to adopt and strengthen national policies to advance South-South and triangular cooperation, and to enhance the capacity of national and subnational coordinating mechanisms as appropriate in order to improve policy coordination, sharing of knowledge, lessons learned, and good practices, and also the adaptation of such practices that also encouraged by the outcome document of the BAPA Plus 40 UN conference held in March in 2019 in Buenos Aires. The challenges that humanity is currently facing due to the COVID-19 pandemic require concerted national actions, global solidarity, and efficient and transformational South-South and triangular cooperation programs to ensure that we are on the right track to achieve the Nairobi commitments within the context of the SDGs and leave no one behind. Sharing effective and replicable best practices is the path to follow for the improvement of policies and programs in developing countries. Today's the objective of this webinar is to showcase and disseminate the best practices among the PPD member countries, also to create a demand among countries for replication of these best practices, and also to establish a virtual forum for exchange of knowledges and experiences among the countries for more South-South and triangular cooperation programs and activities. Your Excellencies, distinguished participants, ladies and gentlemen, the purpose of this webinar is to develop a better understanding of existing and successful ideas and practices with technical, legal, and policy options, as well as promoting access to scientific and technical data, particularly for strengthening the knowledge management among the southern countries. We have assembled a broad and diverse group of well-informed participants for this webinar to learn, share, and also to contribute. I hope that we can do effective knowledge management with your active participation, and also looking not only at what we do, but the way how we have to do it. And I wish to inform you, the audience, that following this webinar, all best practices will be published in a compendium showing that South-South cooperation is about solutions and actions. And for this, I wish to express my sincere thanks and gratitude to Bob Gillespie, President of the Gillespie Foundation, for his financial support to PPD to publish the compendium. Thank you, Bob, for your continued support to PPD since the launching of our organization in Cairo in 1994. Before concluding, I wish to reiterate my sincere appreciation to the Honorable Chair of PPD Board, Madam Lindy Wizulu, who accepted to grace by her presence this webinar despite her busy schedule. I also thank Mr. Hasto Wardoyo, the Honorable Treasurer of PPD and Chairman of BKKBN, for his presence with us and for the great support that we have been provided from BKKBN. My thanks and gratitude go also to Mr. Arthur Erkin, Director of Policy and Strategy Division of UNFPA, and to Inter-Country Cooperation Unit Team of UNFPA led by Mr. Yan Ming Lin. I also thank Ms. Shoa Dassouri, Director of Population Policies in the League of Arab States, and also thank Professor Rizal Damani, our partner country coordinator from Indonesia, who will moderate the panel of today's webinar. Many thanks to all the PCCs present today in this webinar, to honorable board members, to the consultants, and all participants for their presence with us today. Now I wish to give the floor to Mr. Arthur Erkin, Director of Policy and Strategy Division at the United Nations Population Fund, to deliver his statement. Mr. Arthur, you have the floor.
Thank you, Adnan, for your introduction and your kind words. Your Excellency, Minister Lindy Wizulu, Minister of Social Development of South Africa and Chair of the PPD Board. Dr. Hasto Wadoyo, the Honorable Chairman of BKKBN Indonesia and the Chair of the PPD Board. Friends and colleagues from PPD who are, of course, our true partners with us in FPA for the achievement of the ICT program of action, and of course the three results. I wish you all a very good morning, good evening, and a good afternoon, wherever you are. My name is Arthur Erkin. I am the new Director of Policy and Strategy Division of UNFPA, but I'm not new to PPD. Actually, as a matter of fact, I was a very young staffer at UNFPA in 1994, and I was at Cairo at the ICT when the PPD was established. I was there. I feel very attached to PPD. And of course, more recently, I was with many of you at the PPD strategic planning meeting in Beijing in China in July 2019, and I was there to conduct a discussion on the Nairobi Summit. I was then the Director of Communications Strategic Partnerships at UNFPA and lead organizer of the ICPD 25 Nairobi Summit in November. I was so grateful for the strong participation and for the excellent commitments of the PPD member states. And of course, post-summit, we were honored that Minister Zulu made herself available to be a member of the high-level committee that monitors the progress towards fulfilling the commitments made at Nairobi Summit. And earlier in my career, I was the UNFPA representative in Bangladesh, where PPD has its headquarters. So I'm an old friend of PPD, and of course, I hope that in my new role as Director of Policy and Strategy at UNFPA, I will be instrumental in facilitating and strengthening the UNFPA PPD partner in leveraging South-South and triangular cooperation for our shared goals. Today's event of sharing best practices in reproductive health, family planning, and population from PPD member countries is really extremely important in promoting SSTC, or South-South and triangular cooperation. At UNFPA, we strongly believe that knowledge management is an important strategy for programmatic success, such that we are constantly seek to extract knowledge and from field experiences, document them, and then share them widely with the hope that the program managers raise the capacity of our program partners and inspire our stakeholders. But knowledge kept in databases is useless if it's not utilized. It needs to be curated, it needs to be woven into programming guidance, it needs to be celebrated in advocacy initiatives, and shared actively in various means so that it informs the decision-making of policymakers. Knowledge must be dynamic, it must be vetted, and it must be timely. Thus, our exercise today is really very necessary and very important, and I commend PPD for organizing this. Let us also then endeavor to learn and be inspired by the best practices to be shared today and adapt them to our individual local context. Let us recognize the presenters who took the effort to reflect on the lessons and the experiences and generously share them with us today. Knowledge is instrumental in South-South interlingual cooperation. Programmatic best practices are the catalyst of South-South partnerships. SSTC initiatives are formed for the purpose of sharing of knowledge across countries, among many other things, of course. And based on a recent study that we did in UNFP on the costing of South-South cooperation, together with Avenir Health, which is a global think tank in specializing in development program research, we know a couple of things. For instance, that South-South interlingual cooperation generates significant direct returns of investment. The study of a specific Thailand SSTC case on midwifery found that for every $1 of investment that was it generated $4 of social returns. We also know that SSTC generates knowledge that is highly relevant to development contexts and therefore provides effectiveness and efficiency in achieving results. We also know that SSTC mobilizes domestic financing as governments realize that investment in SSTC not only enables them to meet the development objectives, but also contributes to their international relations goals. And of course, SSTC has significant knock-on effects in the form of scaled-up partnership, expansion to other thematic or geographic areas, and generally increase in harmony and peace building among countries. And finally, we've seen that South-South and Treasury cooperation really is a growing movement, as evidenced, for instance, by the strong commitments, of course, at the Papa Plus 40 conference in Buenos Aires in 2019, but also in various international events since then, and in the dynamism we see in PPD itself. And so we will be negligent if we fail to capitalize on this movement for achieving the ICPD goals. Now, going forward, this is what we think at UNFPA we can do together with partners such as PPD to strengthen SSTC. First of all, we would like to see a massive scaling up of SSTC, South-South Triangle Cooperation. There, we've done a recent independent evaluation of our SSTC in UNFPA, and we agreed with the evaluation finding that SSTC has been a very effective program strategy under our current strategic plan, and guided by the management response that was accepted by the executive board. UNFPA will now upscale SSTC as a program strategy in its own right under the new strategic plan. And this move is also very much aligned with the calls of the participants of the middle-income countries consultation that we did last week, and many of you were in that consultation, that some of you attended. So that was very good. We need to scale up this SSTC initiatives. We also know, of course, and we will strongly push the knowledge management of SSTC. We should continue to create knowledge, but also continue to make it widely available and shared widely. Programmatic best practices should be shared through the South-South Galaxy, and of course in events such as this. We want to work very much on also capacity building, guided by our BAPA and Nairobi commitments. We want to continue to strengthen the capacity of countries and agencies to do SSTC, and strengthening national policies and coordinating mechanisms to conduct SSTC, as well as, of course, monitoring. So there's a real desire on our part to do that. And partnership facilitation. Let us raise also the demand for South-South and Treasury cooperation. On the supply side, we will support, of course, SSTC centers of excellence as they are proven, as they have been proven and capable and sustainable, and have highly visible sources of potential partnerships. Madam Chair, in closing, and on behalf of UNFPA, I thank you for this opportunity to reinforce our long-term partnerships, reassure you of both my personal and institutional support from UNFPA to South-South and trilingual cooperation, and of course to the partners in population and development. I wish you all a very successful web development. Thank you very much.
Thank you very much, Arthur, for your statement and for the continued support of UNFPA to PPD and to South-South and Triangular Cooperation. We have common objectives to achieve, and PPD is proud to partner with UNFPA for improving the health and well-being of the people in developing countries. And as you said, you have been involved with PPD since Cairo, since 1994, and now I think we have objectives. Thank you very much. Now it's my privilege to invite His Excellency, Mr. Hasto Wardoyo, Chairman of National Family Planning and Population Board, Indonesia, and the Honorable Treasurer of PPD Board. His Excellency, you have the floor.
Thank you. Thank you.
I'm not sure if I'm the only one who can't hear anything.
Excuse us.
Chairperson, we cannot hear anything. We've been trying to write on the side.
Professor Dominic, we can't hear you. Yeah. Professor Dominic, do you hear me? Can we?
Adnan sir, there is a request.
Yes, can I request
From
Excellency Ms. Zulu to make her statement until we fix the issue with the sound from Indonesia. Okay? Okay. Let's move to the next speaker. Now it's my great pleasure and honor to invite Her Excellency Ms. Lindiwe Zulu, Minister of Social Development, Government of South Africa, and Honorable Chair of the PPD Board. Your Excellency, you have the floor.
Thank you very much, Executive Director. It's a pity we couldn't hear the previous speaker. Hello, I'm here. No, I think there's just something wrong with the entire thing.
Yes, we can hear you, madam.
You can hear me clearly?
Yes, we can.
Yes,
okay,
madam, yes.
Thank you very much. Salutations to everyone. I seem to be hearing myself while I'm speaking, so you forgive me because I think there is a technical fault somewhere. So I will say good afternoon or good morning or good evening to whoever is here. On behalf of the PPD and my government, it is a great pleasure for me to welcome you all in this collective event. I thank His Excellency Dr. Wadoyo, Treasurer of PPD Board and Honorable Chairperson, National Population and Planning Board, Indonesia, and Mr. Arthur Eken, at least I did get to hear him, Director of the Policy and Strategy Division of UNFPA, and PPD Executive Director, Mr. Adnan Benhaj Aisa, for organizing this important dissemination webinar on best practices. May I, from the onset, indicate that I view issues of best practices and any work that is being done around best practices also depending on leadership, number one, and also depending on political will, and also depending on commitment for all of us to really take whatever knowledge and the management of that knowledge and the sharing of the best practices, we must take it to heart and also consider the fact that we do that not for ourselves, but we do it because we want to change the lives of people in our different countries. I'm very pleased to learn that PPD has documented 11 best practices with the financial support of UNFPA during 2019 and 2020 on the PPD's 7 identified priority areas. There is population and development, universal access to sexual and reproductive health and family planning, women, children's and adolescents' health, gender equality, healthy aging, migration, and poverty alleviation, with particular emphasis on emerging population issues. Chairperson, I think I'm always in argument about the issue of poverty, whether it's poverty alleviation or it should be poverty eradication. In South Africa, we use the word poverty eradication because we want to be a country like other countries that are developed, that are known for not having poverty at all. PPD partners, country coordinators have donated their time, efforts, and talent to support consultants from completing the best practices in their respective countries. Without their support, it would have not been possible. I thank all PPD PCCs for their generous support to keep PPD very alive and active. The mandate of partners in population development is to promote South-South cooperation through exchange of knowledge, experience, and best practices among its member countries and other developing countries in reproductive health, population, and development field. The outcome document of the second high level of the United Nations Conference on South-South Cooperation, BAPA plus 40, held in Buenos Aires, Argentina in March 2019, re-emphasized the role of SSC in the implementation of the 2030 Agenda for Sustainable Development. At the Nairobi Summit of ICPD 25 in November, on the 25th of November, South-South and triangular cooperation was acknowledged as an alternative financial tool for achieving ICPD and SDGs. In July 2020, UN Secretary General issued the United Nations Systematic Strategies for SSC, and in January 2021, UNFPA has introduced an independent evaluation report with all member states and the results formatted evaluation on SSC along with the report. UNFPA certainly will strengthen SSC through upcoming next strategic plan 2022-2025, so that globally every sector of actors realize the potential of SSC as a tool to achieve ICPD and SDGs. Ladies and gentlemen, both PPD and UNFPA have joined together with a win-win arrangement to strengthen SSC to achieve ICPD and SDGs through the transfer of knowledge, expertise, technology, and resources. The South-South cooperation provides an opportunity to both a provider country with a win of additional international experience and exposure that may lead to future opportunities in cooperation, trade, investment, and in the recipient country wins by gaining expertise and resources from the provider in an area that was challenging to address by alone without cooperation of others. The political commitments of PPD member countries are stronger towards promoting SSC than any similar intergovernmental organization members who run through the financial and in-kind contribution from the membership. I'm happy to hear that PPD in 2011, first time, a consolidated book titled, I quote, Innovative Experience in Addressing Population and Reproductive Health Challenges in PPD member states, of 9 best practices, published with the financial support of UNFPA, UNDP, the UN Special Unit for South-South Cooperation, and launched the book in Pretoria during its board meeting in presence of my predecessor, Her Excellency Minister Bathabile Dlamini, who was then Minister of Social Development from the government of South Africa. I'm very proud to be part of the 4th successful documentation of 11 best practices from 11 countries, which is a great success of PPD, and making opening remarks as chair of PPD board. Another 11 population policy best practices published by PPD with the support of the Gillespie Foundation in 2012, and later 9 best practices on healthy aging published by PPD in Gillespie Foundation jointly in 2017. A series of international events, forums, and seminars, including China-Africa Forum on Population and Development, have been established in recent years to exchange and disseminate success experience of developing countries in the field of population and reproductive health. The Scholarship and Exchange of Experts program is a unique SSC bridge established by PPD member countries, which contribute to the advancement of knowledge and professional skills development and international understanding in the areas of population and development. India, Egypt, and South Africa are facilitating more than 40 scholarships annually for the young professionals of PPD member countries. And members, of course, it's important for us to note that we are all going through a very difficult time of COVID-19, and I'm hoping that this program will not be disorganized for a very long time due to COVID-19. And I'm hoping that we'll be able to find ways and means, as it is right now, we are finding ways and means of connecting to each other and having these meetings virtually. And therefore, it's important for us to step up to the new challenges. I thank my government for facilitating 10 one-year post-graduation scholarships and 15 short course scholarships since 2010 to PPD member countries to promote South-South cooperation. I'd like to express our sincere appreciation that these knowledge-sharing tools of best practices will help countries to support each other to address country context problems and achieve the national commitments made during the Nairobi summit. I'm happy to hear that with the support of the UNFPA, PPD strengthening national level task force for South-South cooperation to facilitate technical knowledge to expedite the achievement of national commitments. I believe in your collective experience over the years. The willingness to strengthen your existing efforts with support of government will certainly strengthen our collaborative efforts to promote South-South cooperation. The PPD will continue to be an active partner in action to achieve 3 transformative results. The global COVID-19 crisis is an urgent call to action to recover the gains achieved so far and preserve the hard-won progress in reducing maternal, infant, and child deaths, addressing unmet needs for family planning and reproductive health, improving women's health and empowering them in matters of family choice. Population and development issues demand a rethink in a time of crisis to devise new strategies to address emerging population and reproductive health issues through collective efforts. The pandemic outbreak has changed the contours of professional life of our people everywhere. The population problem cannot be a single country issue. It equally affects everyone everywhere. COVID-19 pandemic is not considering race, religion, language, or border when it strikes. This is a crucial moment to pursue innovative policies and programs and look for alternative financial resources to respond to post-COVID-19 recovery. South-South cooperation and partnership can together make a robust response to the crisis. The global response and conduct should attain primacy to solidarity, motherhood, brotherhood, sisterhood, and partnership. Exchange of good practices, capacity building, knowledge sharing, and technical cooperation through promotion of South-South cooperation on policy responses will help mitigate the impact of the pandemic. Enhanced cooperation and partnership across countries offer an effective avenue for building more capacity to create and implement joint development solutions. These solutions are more important ever in the new era of global agreement implementation. SSC is an effective platform for ensuring capacity development, providing a choice of inter-country cooperation and support leading to horizontal partnership, guaranteeing cost effectiveness, providing relevant and multicultural context-specific solutions, and diversifying knowledge and sharing and exchange expertise. Knowledge gaps and resources are major obstacles to progress and realizing the full potential of SSC and its impact on sustainable development. The availability of information and quality of research on the scale and impact of SSC have not kept pace with the growing demand among Southern partners for peer learning to further improve the results. How the impacts of SSC can be maximized and leveraged for health and demographic outcomes need to be clarified during the pandemic crisis. It is very important to explore the progress that has been achieved through SSC. SSC has facilitated the exchange of expertise and knowledge among Southern countries through supporting each other's programs and activities, which will continue to help solve many problems within the Southern countries. During the global COVID-19 pandemic, Southern countries supported other PPD member countries with medical team, masks, ventilators, and other personal protective equipment. Some evidence has been found in cases of providing technical assistance for the exchange of best practices, despite the main intervention areas of SSC being the exchange of knowledge and best practice amongst countries. Effective SSC in population and development depends on institutional arrangement at individual country levels, but there are critical challenges for institutionalization of SSC. The International Interministerial Conference on SSC in Population Development is a unique high-level international forum where policymakers exchange their knowledge and lessons learned from the practices. We need to work together and find solutions collectively. While the year-long pandemic crisis is threatening progress towards ICPD and SDGs, it makes the country's attainment in these areas all the more urgent. Despite SSC's contribution in achieving ICPD and SDGs in recent years, there are critical challenges that have undermined the potential of SSC. These are COVID-19 is one of the greatest challenges in promoting SSC population and development. It has negative impact on poverty, health and well-being, and has disrupted economic and social development in developing countries. Dynamism in leadership and political commitments with ownership and knowledge are catalysts for promoting SSC, but these are lacking amongst the Southern partners. Young people represent 50% of the population of the developing world, but there is lack of meaningful engagement of young people in promoting SSC in bringing about innovative solutions. Centers of excellence are needed for innovation, new partnership, knowledge sharing, and scaling up proven approaches. But there is lack of centers of excellence in SSC population and development. Institutionalization, operationalization, and accountability of SSC are lacking amongst countries. Institution building is thus essential for promoting SSC. National budget allocation for SSC and donors or international agency priority funding, especially for SSC in reproductive health, population and development, are quite insufficient. A national support structure comprising of task force, think tanks, and networking research and training institutions and NGOs is needed for identifying national levels policy gaps and formulation of policy initiative. Lack of support structures under the visibility of SSC. Success of SSC is undermined by the absence of well-defined national policies of SSC that need to be invigorated through national commitment. Southern countries do not have sufficient tools to measure and evaluate how exchange of knowledge, skills, resources, and technical know-how through SSC contribute to the global agenda. I believe, ladies and gentlemen, we need to find jointly transformative pathways to build better South-South cooperation. Southern countries can build a strategic partnership and take coordinated action around three basic principles: scaling up best practices, mobilize resources of recovery from the pandemic, enhancing policy and program space, and building capacity and resilience. Experience and information sharing and replication for policy and program changes, especially among the Southern countries, is important approach to win the battle against COVID-19. The format of experience and information sharing could consist on online webinars, in-person seminars, electronic newsletters, social media communication through Facebook or Twitter, and development of, I quote, best practice in the areas of reproductive health, family planning, and so forth. Initiating South-South integration project in South could help countries jointly meet the challenges of post-COVID-19 recovery, and the countries of PPD do need special attention and focus on national capacity building for maternal health and gender-based violence in particular, in the context of the Nairobi commitment. Organizing joint fellowship aiming to expand institutional capacity to promote exchange between young professionals and managers in the South, while addressing SRH, maternal and child health. Strengthening national task force for South-South cooperation to promote multi-country bridge research, advocacy and leadership and policy interventions. Setting up SSC pharmaceutical forums to strengthen the capacity of producing new medicines, vaccines, and medical equipment, considering the emergency demand of developing countries. Building and developing more effective centers of excellence and training national focal persons on South-South and triangular cooperation are an effective way to build national capacity for maternal and child health, reproductive health. Digital monitoring tracker for SSC in achieving ICPD 25 and SDG is required to make sustainable financing for SSC. Lastly, I wish you success in your discussions. I hope you find courage in what has been accomplished this far, and I hope you find renewal of strength and commitment for the work you set for yourselves. I trust your work will lead to effective action that definitely help each other to find solution to achieve ICPD and SDGs by the year 2030. Thank you very much, Program Director. And I wish to also thank the presenters who are about to present now. The work that they have done, I think, is highly commendable. Thank you very much.
Thank you very much for the promotion of South-South and triangular cooperation under your great and committed leadership. Thank you again. Now, I was informed that the sound has been established in Indonesia, so I will invite and the Honorable Treasurer of PPD Board. Professor Rizal, you have the floor.
Thank you. Thank you, Mr. Adnan. So, Honorable Chair of PPD Board, Her Excellencies Lindy Wee Zulu, Honorable Partners Countries Coordinators in Partners in Population and Development, Honorable Executive Director, Partners in Population and Development, Mr. Adnan bin Haji Aisha, Honorable Director of Policy and Strategy Division, UNFPA, Mr. Arthur Elkan, Honorable Director of UNOSSG, Mr. Tariq Izirain, Honorable Director of Population Policies, League of Arab States, Ms. Chowa Desauki, Honorable Ambassadors, Speakers, and Resource Persons, Ministers and Boards, Local Government, Civil Society Organizations, Indonesia's Heads of Provincial BKKBN Representative, distinguished ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon from Jakarta. I would like to request your permission to deliver the remarks on behalf of the chairman of BKKBN, Dr. Hasto Wardoyo, due to his appointment. He would like me to deliver the remarks on behalf on this occasion. So first of all, praise to Allah Subhanahu wa Ta'ala, Almighty God, for His blessings on protecting us from COVID-19 pandemic. Indonesia and I believe the rest of the world will continue to make efforts to overcome the transmissions of COVID-19 so that we be able to interact again without fear. As part of the executive members in the International Partners in Population and Development Organizations, BKKBN together with PPD Secretariat are honored to be able to host this international webinar. This webinar is expected to be a means of increasing international solidarity, especially South-South countries. The webinar aims to, first, showcase and disseminate 11 best practices among the PPD countries. Second, to create demand among countries for reverse linkage to exchange knowledge for replication of best practice. And third, establish virtual forum for exchange of knowledge among the countries through South-South cooperation. We would like to take this opportunity of this precious moment to convey several things, namely, one, as one of the countries that signed the 1994 ICPD Declaration, Indonesia has a strong commitment to achieve the ICPD Program of Action, the 2030 Development Goals and the Sustainable Development Goals, and also a commitment to ending preventable maternal deaths, unmet need for family planning services, and gender-based violence and harmful practices. Efforts to achieve the targets set out in the ICPD and SDGs are manifested in concrete manner in the long-term, medium-term development plans, national strategic plans, as well as a supportive funding framework between the central, regional, and village governments. Second, Indonesia is projected to become 9 countries that are part of half of the world's population by 2050, encompassing population management, including true universal access to reproductive health. Until now, we are still struggling to reduce per 100,000 births and unmet need to 7.4% by 2024. Indonesia is also working to accelerate stunting reduction to 14% by the year of 2024. Third, in early 2021, the President of the Republic of Indonesia gave a mandate to the BKKBN as the Chief Executive to accelerate stunting reduction. So far, the decline in stunting rates in Indonesia is still at 1 0.6% per year. Through this assignment, the President has a target that at least every year the stunting rate in Indonesia can be reduced to 2.7%. In carrying out this task, BKKBN, with a number of ministries, have a direct extension to the regional level and formulate concrete steps to deal with stunting problems in Indonesia. In the Nairobi Summit, Indonesia is committed to end three things, namely preventable maternal mortality, unmet need for family planning services, and gender-based violence and dangerous practices. Indonesia is committed to reduce unmet need for family planning from 10.6% based on National Health Survey in 2017 to 7.4% in 2024. Reduce maternal mortality from 305 per 100,000 in 2015 to 183 per 100,000 in 2024, and reduce the prevalence of violence against women aged 15 to 64 years in the last 12 months from 9.4% in 2016. One of the key things that the Indonesian government do is developing synchronized policies, strategies, standardizing service quality, and also resources to resolve these three problems. Therefore, policies and strategies related to the spirit of the 3 zeros are important to be implemented in a quality and on-target manner. All of these efforts focus our attention on access to information and services for women and girls. 6, I believe that all countries are currently struggling to cope with the impact of the COVID-19 pandemic. Therefore, new evidence and research is urgently needed to enhance our understanding of crisis in developing countries and appropriate policy responses. Based on the Buenos Aires Action Plan for the promotion and implementation of technical cooperation between developing countries, Indonesia consistently contributes to South and triangular cooperation. With the spirit of e-STC, this international webinars aims to improve communication among developing countries, awareness of common problems, and wider opportunities for collaboration. Finally, I would like to express my gratitude and appreciation to the chair of PPD board, board members of PPD, executive director of PPD and UNFPA for their support and collaboration with BKKBN for all this time. Hopefully, this good communication and cooperation will continue in the future. May God Almighty give the abundance of His mercy. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Rizal Damali, for delivering the statement on behalf of His Excellency, Mr. Hasto Vardoyo. Excellencies, distinguished participants, ladies and gentlemen, the opening session now is coming to the end. And I would like to come back to my friend and my colleague, Professor Rizal Damani, Partner Country Coordinator and Deputy for Training and Research, BKKBN, to moderate the panel, the session on the presentation of the best practices from PPD member countries. And kindly request him to remain within the time allocated for the session. So request consultant to limit their presentation within the time allocated. Before giving the floor, I wish to thank my colleagues in the Secretariat for their efforts and hard work to prepare this webinar. We have been working for more than 1 month now in preparation of this webinar, and today I'm happy and I'm proud to have this the result of our efforts, and also to have this webinar in collaboration with the BKKBN and also with UNFPA. Thank you very much, Professor Rizal Dominique. You have the floor to continue the session. Thank you.
Okay, thank you. There?
Yes, yes.
Okay, good afternoon, Excellencies, ladies and gentlemen. Firstly, I would like to thank you for your attendance on today's webinar under the theme webinar on sharing best practices in reproductive health, family planning, and population from PPD members countries. It is my pleasure to be a moderator for this webinar. My name is Professor Rizal Dominique, Deputy for Training, Research, and Development of BKKBN Indonesia, and as Partner Country Coordinator of PPD. This webinar is held by the cooperation between PPD, National Population and Family Planning Board of the Republic of Indonesia, and the UNFPA. Distinguished guests, as we know, South-South cooperation plays a strategic role in implementing population and development program on the global, regional, and national level. PPD is an intergovernmental organization, currently has 27 member countries, sharing the same principles and committed to attaining their shared vision in leading promotion of South-South cooperation towards the attainment of the global population and reproductive health agenda for sustainable development. PPD and UNFPA jointly committed to working for the documentation, dissemination, and replication of best practices to respond to PPD member countries' specific needs. Efforts were made to document 11 best practices in 2019 and 2020 on specific topics related to family planning, reproductive health, maternal health, adolescent health, gender equality, population, and development. At this opportunity, we will disseminate 11 best practices among the PPD countries. Furthermore, we will discuss and share experiences regarding those best practices from our valuable panelists from 11 countries, namely Bangladesh, China, Egypt, India, Ghana, Gambia, Kenya, Morocco, Thailand, Tunisia, and Vietnam. Each presenter will have a maximum of 3 minutes to present. After all of the panelists finish giving presentations, our discussants, the Honorable Professor Joshua Kembo, will share his comments on insight into the presentation. And then the last 15 minutes will be allotted to questions and answer before closing the panel discussion. We invite participants to ask questions in parallel during the speaker's presentation through the Slido link shared in the chat box. Excellencies, ladies and gentlemen, to begin this program, I'm pleased to invite Mr. Muhammad Shahriar Nafis from Bangladesh to deliver his presentation titled Maternal Health Free Capacity Model. Mr. Muhammad Shahriar Nafis, the floor is yours.
Good evening. Good evening from Bangladesh. I'd like to share my screen. Can you
Yes, it's already open.
We can see.
Yes, you can see. You can speak now.
Thank you. Thank you, sir. So my presentation is on the maternal death-free capacity model. I'm presenting now. I would like to. I welcome you all, respected participants, to this presentation of maternal death-free capacity model. This is a great opportunity for me to work on this documentation preparation and to present this model. Thank you, PPD. This model was officially inaugurated in practice by Mr. Abdul Rahim, who
Hello?
slide. I go to the second slide. This model is developed for the benefit of low-income population, and approximately 20,000 pregnant women since December 2017 been served under this model. The main purpose of this model is to raise awareness through information availability to beneficiary group and increase service delivery simplifications. The methodology we used to document these best practices, we used information from school teachers, writer journalists, pregnant and recently delivered women, family members, blood donors, community health workers, member from Indian Coalition, etc., etc. I have been personally visited the pregnant women home to know about ANC and PNC services they avail from satellite clinic and community clinic, etc. And the leadership for whom this model is inactive in Kapashi right now, I haven't visited. About this model. And the main purpose of the model, the objective of the model, were the three iconic objectives that we have found so far. It was the reducing maternal and child mortality, raising awareness of pregnant mothers on issues pertaining to nutrition, prenatal and postnatal care, child care, family planning methods, and the last, the availability of information and service simplifications. So I included all the things about the model in this single format. This model is the result of government, local administration, and community support. I tried to encompass all the compressed in one table. And you would see that the support is divided into two parts. One is from UFPO, and the others are local administration and community support. From UFPO, the field level support is ongoing. The officials are working relentlessly to support the pregnant women and children. They have been tagging their name plates outside their homes so the community people can find them easily. You can see in one example in the photo that the community, the field worker, they are tagging their names on right of the residents so that people can get in touch right away. So the base part of the model is to invent software or mirror of pregnant women, they say, for the pregnant women. This software is invented to award the pregnant women through SMS and voice over message for ANC, PNC services. This database is also managed for the nearest blood donors and the photo writer list for the MA pregnant women. Under this model, a book named Ornament of the Mother is being published for pregnant women. So this book is issued with individual ID to each pregnant woman. This book includes record information like emergency corporate numbers, ANC, PNC dates, etc. And the pregnant women get discounts on submission of this book at UPSC, Reproductive Health Complex, for diagnostic tests. The subsidy is given for if the pregnant woman can submit this book. Pregnant Mothers Assembly is organized in each union. Honorable MP is involved with this program. Quality service delivery, free ambulance support, all are issued under this model. And the most important part is the donation is received from each month from the 1,700 government officials working right now in Kapasia. And this the small amount is donated from their salary account to this humanity sec fund, like 30 Dhaka Bangladeshi amount and like the 50 pence per month. And all this amount together, it becomes like US dollar $650. And this amount is donated every month for the supporting the pregnant women and all other record things for this model to be sustainable.
Please manage your time, Mr. Nafis.
Sorry.
The time is almost finished. Then.
Oh yeah, I'm just finishing. This model
Okay.
is supported
Thank
by
you.
cooperating people,
Okay.
blood donors from student associations. So it's a sort of strength of the model is the information, all the components help the model to become accepted in Kapasya. And pregnant women receive SMS and voice over message in Bengali well ahead of ANC and PNC services. So I just want to show you the maternal death ratio. It now is decreased from 2016 to now. It is now near about to 0. And newborn and child and infants even get near to the this rate right now. You even see this in the screen. And impact, almost 0 maternal rate, newborn rate significantly reduced from 12 rate right now, and stillbirth decreased from now it's 19. So
Okay.
if you see the model working in COVID-19, as there is a improvement of this information technology, so officials don't need to go and the pregnant women get the information right on their mobile phone. So this maternal-mortality ratio, you know, this is now decreasing in Bangladesh. So if this model is going to continue in other parts of the Bangladesh, we hope that we'll get the digital 2030 target under the leadership of Prime Minister Sheikh Hasina.
Okay.
So replication, the last slide, if we want to replicate in SSC, so it should have the field level force like Kapasya model, and the social engagement or community participation needs to be ensured for this pregnant woman. So if yes can be issued, the SSC will be get benefit like the Kapasya model. Thank you, sir.
Okay. Thank you, Mr. Nafis, for that insightful presentations. Please be aware to the presenter that the allocation time is about 3 minutes. Next, it's my pleasure to introduce Dr. Wang Ailing from China with the presentation Maternal Care Service during COVID-19 pandemic. Dr. Wang, the floor is yours.
Yes, I'm here. Can I share my screen?
Yes, please. Mr. Nafis, can you stop the sharing your presentation?
Please.
You can share your. Please, Dr. Wang.
Yeah. Please, can you?
Have you shared your presentation?
I share already. Just a minute. Can you hear? It's okay?
Not yet.
Oh, thank you so much. Thank you, PPT give us opportunity. Can you hear or see the PPT?
Not yet. Can you, oh yes, yes. Okay. Okay.
This is my my team to writing. It's nice for us to write the best practice to summarize the maternal care service response to during COVID-19 in China. The goals and the principles of maternal health response in China is for us. The first one is to keep pregnant women and children free from the COVID-19. The second point is all pregnant women can access regular maternal care and delivery care service during lockdown or quarantine. The other one is pregnant women with COVID-19 can receive both timely treatment toward worries and maternal and delivery care service. So we should prepare the maternal care and the COVID-19 protection service to pregnant women and their newborn infants to ensure the safety of mothers and children. Follow the goals with clear responsibility of different perspectives. For local government, they should pay more attention on allocate the strengthened medical resources, designate local designated hospital prepared for the quarantine perspective and the emergency equipment and the supplies. Also, we want to mention adjust the network and the resources of near pregnant women for their prevention and how to say treatment. For hospitals, we have a list of their responsibilities for during the COVID-19. They are most we want to emphasize they should have the other ways to change with their treatment and to care accessible for the pregnant women. For medical staffs, also we want to have a list for their responsibility. For example, Western knowledge and information on COVID-19, they should have to learn. The other one is identify and report case timely. And the third one is provide online counseling and direction service toward all pregnant women. The other one is the infection prevention during all service. For pregnant women and their families, we also ask them to learn how to protect themselves during the COVID-19. Also have the way to access how to access the doctor and the nurse. So there is we emphasize the different responsibility during the COVID-19. For the at the last year at the February, we already have the policy response. For example, timely released national policies and technical guidelines on COVID-19 prevention and management among pregnant women and children. We want to all the notice to how to prevent and management infected pregnant women and children and their children during the outbreak. Also, we want to strengthen management of pregnant women and the insurance safety of motherhood during the outbreak of the COVID-19. For service, we want to change the procedures because it's always face-to-face, but now we cannot, pregnant women cannot go to hospital, so we will change the online. For example, WeChat, we also have media apps and hotlines and video. So it's easily for them to get the counseling and the direction from the doctor or nurse. We also have a 1700 at the February of 2020. We have a 1700 hospital to designated hospital because it's open to the society and every people can know the list of the hospital, and the hospital also have responsibility to get the pregnant women. So in order to ensure timely direction and the treatment of pregnant women.
Your time, please, Dr. Wang.
Okay. The other one is for the infected pregnant women and the children. They all have go to the designated hospital. We also have the expert groups to them including other perspective. So I want to ask because time is too short, and I just want to 3 points to last one. One is the timely release the national policies and technical guidelines on COVID-19 prevention and the management among pregnant women and children. The second one is optimizing the operation of MCH service system to adapt the changing situation during the outbreak. The last one is strengthening prevention of maternal and child health service through different channels and platforms. This is just a brief introduction. Thank you. Finish.
Okay. Thank you, Dr. Wang, for another insightful presentation. Next, it's my pleasure to welcome Professor Ashraf Nabhan from Egypt with the presentation Yamna Ahla initiative. Professor Nabhan, you may start your presentation now, please.
Thank you very much. let me share my screen with you. I think you all can see the PDF. And I pledge that I will not extend beyond the 3 minutes limit of my time. Ayam Ahla, it's an Arabic word for better days. We want to make days better for everyone in our community and every community in our world. Greetings from Egypt. One day, after this pandemic, we might all share a pleasant evening by the Nile and the pyramids. The idea behind our project was to address non-issues detected in the 2014 DHS in Egypt. A decreased exposure to family planning, reproductive health messages, decreased information counseling, and the discontinuation rate due to myth regarding side effects, and fewer young women using contraception. And the themes of the project included 3 cutting themes: knowledge utilization, right to reproductive health, and youth. The project included a bundle of proven high-impact practices within 2 categories: social behavior change and service delivery. It was conducted by the sector of family planning at the MHP in collaboration with relevant stakeholders. This is the framework of the project. We have challenges, lack of knowledge, negative attitudes, norms that discourage contraceptive use, and we have that bundle of interventions, of proven effective interventions. As you all know, implementation is about implementing something that we know that works. And we know that proven high impact practices pertaining to social and behavioral change, proven high impact practice pertaining to service delivery, they are bundled together in order to achieve and increase awareness, supportive attitudes and values, intention to use contraception, and changing the norms that support family planning. And we have the outcomes of the number of women receiving covered, and especially with the long-acting contraceptive methods, years of protection, especially using the long-acting methods. And the major findings, the indicators showed all plus changes as compared to the same season or month or quarter of the last year, when we before starting this project. We have a surplus increase in the total number of beneficiaries, visits, new users, the number of recipients of contraceptive methods, and the years of protection achieved, especially with the long-term methods. We can speculate that these surpluses in those outcomes would contribute to achieving major SDGs, especially number 3, ensuring healthy lives and promote well-being for all at all ages, and achieve gender equality and empower all women in our community. Is it replicable? Of course, it's replicable. The best practice is an excellent example of replication that might work in other countries through South-South collaboration. This can be achieved by collaborating with and working through national organization partners who are who understand the preferences and values of the target groups and are aware of the local conditions. For example, you can mediate the viral message that we used in the social and behavioral change through social media. Different platforms have different penetrations in different communities. For instance, I'll give you an example. In Egypt, the mobile penetration is 110%, which means that there are more than 100 million SIM cards distributed in the population. In comparison to other South countries, you find the penetration is 50% or 30%, 40%. So although we know mHealth works, but it might not be that effective in a country where the penetration of mobile or e platforms are less than other countries. even within the same social platform, you find differences between communities, and the challenges are different. So we need to understand in each country the challenges, we need to the players and actors, and then the best way to deliver this kind of What was the lesson? Briefly, a carefully planned and rigorously implemented bundle of high impact practices are adequate, effective, efficient in terms of process and outcomes. Thank you. Now, for this, back to you, Mr. Chair.
Okay. Thank you, Professor Nadan, for the fantastic presentation. I'd like to invite Dr. Nindi Ba from India to deliver presentation titled Introduction of Postpartum Intrauterine Contraceptive Device Services. Please join me in welcoming Dr. Nindi Ba.
Thank you very much for giving this opportunity to talk about the best practice coming out of India. I'd like to share my screen. Just a moment. Okay.
Okay.
So I'll just request Arima to move the slides faster. The moment I tell you, then you please just move to the next slide. So this is about the scale up of the postpartum IUCD services. And this is a challenge that we took upon ourselves to address the reproductive health, population and development challenges. Next. So the need for this was arisen from the simple fact that there's a very high unmet need for contraception in the postpartum period to the tune of 65%. And as well as another factor is the return of fertility as early as 4 weeks after delivery and within 10 days after an abortion. That's the reason why we really put all our efforts in this arena. Also, there was global focus around the healthy timing and spacing of pregnancies. There was a paradigm shift from limiting to the spacing methods. Then there's a question factor of the high institutional delivery. In our country, initially we had only around 40% delivery about 20 years back in the institutions. Right now it's hovering around 80 to 85% across the country. And then there was focus on also long-acting reversible methods. Next. So our goal was to improve the maternal and child health outcomes by addressing the unmet needs of spacing, especially in the postpartum period. Next. So the program evolved. So in different phases, 5 phases we have mentioned. The first was initially in 2006, there was a global commitment for healthy timing and spacing of pregnancies, and backed by evidences, we started the initial dialogues to revitalize postpartum IUCD in India around the year 2008. Next. Then in 2009, we came out with the new key strategies. We piloted this particular thing in 1 national level and 3 regional level training centers, wherein we talked about finalization of the service delivery tools, involvement of the national and state stakeholders, implementation at the field level, and also institutional line of services. So these were all sequentially taken up, and it really had multiple micro plans under each of those headings. Next. So in 2012, we were able to expand it to 19 of our 36 states. It also witnessed the advent of the combined RM and CHA strategy in our country, together with the focus on family planning because of the advent of the Family Planning 2020 movement, which started from London. So strengthening of the postpartum family planning was one of the national commitments of India under the Family Planning 2020. And what we learned from the pilot also resulted in really Government of India's policy shift in 2012. We really put in dedicated counselors in the government system. Then we resorted to task shifting, wherein we allowed nurses to do this insertion of the postpartum IUCD. Also, we allowed our indigenous doctors who were conducting deliveries to insert these PP-IUCDs. Also, we scaled up the PP-IUCD services at around 250 district hospitals in 6 of our 36 states in the year 2013-14. Next. So what did we do going on for scaling up the services across all states? We had initiatives on the supply side as well as on the demand side. On the supply side, we developed learning resource packages. We started training sites and developed the criteria for that. Even the equipment part was something which we developed indigenously. And then supply chain of the family planning commodities was really looked into. and the providers, the training part into account on the supply side. On the demand side, we started capacity building of the frontline workers, mass media materials were in place, and also improved the quality in service provisioning in terms of informed voluntary consent, data recording, and adequate financing. Next.
Okay.
So if you see 2014, where were we? There was successful demonstration of collaborative efforts towards overall health system strengthening with a common objective of reducing the unwanted pregnancies and ensuring healthy technical support unit to really run this program across the country. Next.
Okay. Manage your time, please.
Next. So, yeah. So because of the slides, I think it's taking a little bit of time. So the 2018 country plan, so this is the impact which came in terms of, you see the performance in around 2 million numbers, which is the highest in the world. And the second highest country is nowhere near. Next. Next.
Okay.
Next slide, please. So this is the impact.
Okay.
Can we go back to the previous slide? Actually, this is the last slide. Yeah. So what did work? We had options in the governance mechanism, in development of the health workforce, worked in the financing arena, service delivery, as far as health information is something which we looked into, and also the access to community. So what we learned was that there was a constant need for demand generation activities, developing mechanisms to bust several myths, and institutionalization of the program strategies. Next.
Oh.
So this is the last slide. Way forward, strengthening the post-abortion family planning, especially post-abortion IUCDs, periodic reviews and monitoring, developing e-modules for ongoing trainings in pandemic times, national family planning.
Okay. Finished. Thank you. Thank you, Dr. Bhatt, for a very stimulating presentation. Now, I would like to invite Penat Erasmus, Mr. Kojo Fikpe, Latte from Ghana, to deliver a presentation titled Adolescent Reproductive Health Project. And Mr. Kojo, time is yours. Mr. Kojo? I was informed that Mr. Kojo has a technical problem. Mr. Kojo? Yeah, okay. From Ghana. Mr. Kojo, if you're in. Please unmute your computer. We can't hear you. Unmute, please. Apa? Problem. So still have a problem, Mr. Kojo. Maybe we skip him first and then back to him again when he join us. Next, is my pleasure to welcome Mr. Lamin Nyabali from the Gambia with the presentation titled Male Action Group as a Best Practice for Reproductive Maternal Neonatal Child and Adolescent Health. Please join me in welcoming Mr. Lamin Nyabali. Mr. Lian Nyabali. Mr. Nyabali also lost connection. So I try to back to Mr. Kojo Fikpehlarte. Mr. Kojo from Ghana. You are the co-host now, Mr. Kojo. No response? Okay.
Professor Damani. Then come back to the speaker and we already solved it. I think we can move to the next speaker.
Yes.
Thank you.
Can you hear me, Prof.
Who is speaking, please?
Yeah. Good afternoon.
I can't hear you clearly.
Can you hear me, Prof.
I think your signal is not stable yet. Yeah, maybe you can.
Prof, this is Bernard Kudu Pilati.
Oh, okay.
You can't hear me?
Yeah, I can hear you.
Yes, from
Hello,
Ghana.
Prof.
From Ghana.
Yes, it's not stable. Yeah. And my signal, I'm having challenges.
Yeah, your signal is not stable. Look like for me here, from here.
Can you hear me, Prof?
Not stable. So
Yeah.
I would recommend you to sign out first and then sign in again. Yeah, please sign out first.
Can you hear me, Prof?
And then join back again. Okay, I will call you later. Next, I'm very pleased to welcome Dr. Alfred Agwanda.
I have challenge with my
Can you hear me? Can you hear me?
Okay.
Okay.
Okay, you sign up.
Yes.
Okay, you sign up.
Okay.
Alfred.
Alfred.
Okay. Can display put the presentation on?
Yes, I can hear you, Mr. Alfred Gwanda.
Can
okay, please share
your yes. Though it's with the co-host, they can put the presentation on.
Okay.
I shared with them so that they can present the yes.
Okay.
Yes, sir, we are sharing the Kenyan presentation.
Okay. Please manage your time, Mr. Agwanda, Dr. Agwanda.
Okay, fine. I think my presentation is not on the programs, but basically how policy communication. Generally, since the ICPD and then the SDG, the policy communication framework is changing. And also, the focus is now on the individual, and therefore we look at policy communication to be having a sustained iterative system of information and exchange that involves several people, leaders, communication agents, stakeholders, and others, so that they foster dynamic, versatile, and responsive approach to policy. With this, the policy communication system is a complex process. A broad range of organizations are involved, actors, individuals, and many of whom may not be unaware of their communication value to their roles. Therefore, move to the next slide. Next slide, please. Next slide, please. Okay, my presentation is about policy communication that involved population, health, and environment at the extreme process, complex process that involves people, their health, and their natural resources. The initiatives of integrating programs to address both social and environmental challenges have been with us since 1980s. And a number of them, since the beginning of this century, have begun to focus on complex projects that involve population, health, and environment. In Kenya, there are slightly more than 10 projects that take this approach. And two issues can be said to have initiated the process. That one, lack of the documentation of the benefits of PhD integration. Just like many other projects have a lot of innovation, but we do not document. But in this one, there are also some critics who said that the value added was not low, was low. So Mexico, 1984. Next slide. Next. Okay. So Engage program, I think will share will show us we'll share the presentations and the write-ups, but it was a toolkit that used to disseminate information to various platforms. As you all are aware, we have had kind of an exponential growth in the way we have media and use them appropriately. The main goal was to act as a catalyst to trigger and stimulate policy dialogue, to promote and advocate for PhD programs and policies in Kenya. That was the main objective. And therefore, you needed different actors, different organizations, different individuals, and also the communities themselves. Therefore, this communication involved a multimedia presentation that was developed both in English and also the local national language, Kiswahili, so that both technical and non-technical actors can be able to understand the process, the goals, and so on, and what the activities they are supposed to be responsible for. Key achievements. Yes, between 2014, 2017, and up to 2019, we had a lot of high-level discussions at national level, at the local administrative and community levels. And these discussions not only involve the people who are acting directly, but also those who are communicating, particularly the media houses, both print, broadcast, digital. The only thing that it didn't involve was the social media, which was by then under development. One key achievement of this was developing new influencers and leaders in FP, reproductive health, and also through policy communication in training and related programs. But there's one anchor which was very important, that the data systems, so that we have a clear understanding of the stories and the implications of the policy actions, both non-technical and technical people. And that's how it was it spread the communities, even where programs had left, the activities continued to sprawl within the communities. And it was also led to communicating difficult concepts such as demographic dividend, but it could be understood through well-crafted and acceptable presentations. Consequently, a roadmap was built that focused on FP 2020 and SDG objectives, that you are dealing with a whole person, therefore do not present what programs to this individual vertically, but in a process that they know each other.
Okay, your time.
Well, finally, a key lesson that is learned is that the projects can be used to develop and support disseminate actions. It's a strategy that we need to keep awareness that policy options involve these actors and so on. Thank you.
Thank you, Dr. Awanda, for your excellent presentation. Ladies and gentlemen, I'm calling back to the fifth speaker from Gate. Are you joining us already? No response. Mr. Lamin or Mr.
Hello.
From Ghana.
Hello. Hello. Good afternoon, Prof. Hello. Yeah. Good afternoon, Prof. Riser. Good afternoon, Prof. Riser.
Okay, good afternoon. Mr. Kojo from Ghana.
Yeah. Yes.
Okay, your floor is yours now.
Kojo from Ghana. Yeah. Can you hear me, Prof?
Yeah.
Can you ask them to put my slides
okay,
on the
try
screen?
again. Can you?
Okay.
Okay.
Can you please?
It's on the screen now.
Ask them to put my slides on the screen.
It's on screen, Mr. Latte.
No, it is not.
I'm sorry.
I can't find my slides.
Mr. Kojo, your voice is breaking. It's not clear. Yeah, I can't hear you clearly then.
Can you hear me?
No, the voice is breaking. It's not clear. So I think you still have a signal problem. Maybe you can try to find maybe the good location, so we can hear your voice clearly then. So sorry for that. I'd like to move to the next speaker, from the Gambia. Mr. Lamin Nyabali, can you hear me? Are you already in? From Gambia. Not joining us already? Okay. Moving to the next speaker, would like to invite Mr. Laksir Abdelila from Morocco.
No, I am joining you.
Introduction.
I'm joining you. I'm joining you. Lamin from Gambia. Are you hearing me?
Okay, I can hear you.
Can someone?
Okay, Lamin Nyabali from Gambia.
From Gambia, yes, yes. My presentation.
Okay.
Can someone put the slide presentation, my presentation, please? Can you share it with me?
Yeah. Okay. It's on screen now.
It's on screen now. Thank you very much for giving us this opportunity. On favorable demographic indicators in the country, in the Gambia, which include high levels of infant, child, and under 5 mortality, high unmet need of family planning, low use of modern contraceptives, limited involvement of men in reproductive health, gender inequality, and other social cultural constraints have led to the Gambia developing and implementing innovative strategies to address sexual and reproductive health in the country. One of these strategies is the Kabilo-Bama, and next slide, continue, next, come down, Kabilo-Bama and Kabilo-Fama project, which was implemented in one of the regions called the Lower River region. The objective of this particular initiative is to increase utilization of reproductive health care services, also to promote male involvement and participation in reproductive health, to increase uptake of modern contraceptives, to empower women and increase their earnings through livelihood skills development. So the steps taken to implement this activity includes the following. First and foremost, we ensure anybody who is implementing an activity of this nature should ensure that in any country, the country is safe and peaceful. Then the location of the project should also be problem-free. Then with those three conditions met, the first thing that we had to do was to conduct a research and identify communities with low uptake of reproductive, maternal, neonatal, adolescent, and child health services. Next. When this was done, the research was conducted. Then we compiled also service statistics from health facilities in the areas where the intervention is also taking place. Then these two data is analyzed and a project proposal is developed. This proposal developed contains a comprehensive monitoring and evaluation plan in place. This is to get ready for the project. Now, the next thing is we engage the communities. Wherever this intervention would be implemented, you have to engage the communities by visiting the head of the community, the head of the village, and also something called the village development committees, to explain your mission to them so that you can solicit their support to implement the initiative. When that was done, then there was selection of what is called Kabilo, Bama, and Fama. Kabilo comprised of people living together, usually family members. They are closely knit. They have common values. It's an entity within a village or a community. Each of those Kabilos would identify 2 females and 2 males for the initiative. When those males and females are identified, there will be training materials that have already been developed. These training materials are developed in a very culture sensitive manner. Because these are people, some of whom have not even been to school, and some of them, are so culturally oriented. After developing training materials, then, guidelines, training is provided to those representatives. After the training, guidelines are also developed, followed by ongoing sensitization, then monitoring and evaluation. Next, please. Next slide. Then the achievements. When these things were accomplished, there was an increase in awareness on reproductive health issues in the communities of intervention, increase in early booking, registration of pregnant women. There was sharp reduction in maternal death. In some areas, they have reported 0 maternal death. There was increase in birth attended by skilled personnel. There was increased male involvement in reproductive health and child health. Hitherto, men always see RH as a women domain. They have not been supporting. They have not been giving the kind of support that we require. But with this intervention, they were even accompanying their wives to the health centers. Also, there was skills developed, because one of the prerequisites is once you are doing an intervention like this, you have to empower the women. You have to empower the beneficiaries by giving them some skills that will be used to enhance their income and to ensure that they implement the program accordingly. So skills have also been developed for the beneficiary communities through some soap making, through some batik and other activities. So income also of the same community also increased. So a few of the challenges that I would like to highlight is they've had transportation difficulties of transporting women from the communities to the health centers. They continue to face some of those difficulties. Now also funding for reproductive, maternal, neonatal, adolescent and child health activity within the community, they felt that the amount of money available was not adequate.
Okay.
And also income generating activity, which is key to sustainability of the project. They also said the income generating opportunity that they have in the community needs to be enhanced. They need more opportunities to be able to boost their incomes. So in terms of replicability, this particular intervention is currently being replicated in other regions in the Gambia with success. WAHO, which is West African Health Organization, is also supporting the initiative for further replicability, in other parts of the country. Thank you very much for giving us this opportunity. Thank you.
Okay, thank you, Mr. Nyabali, for an informative presentation. Moving to the next speaker, again, I'd like to invite Laksir from Morocco with the presentation, introduction of the contraceptive implant to reposition long-term methods in family planning program. Ladies and gentlemen, please welcome Mr. Laksir Abdel Dira.
Thank you very much, Chair. Can you hear me?
Yes, clearly.
Hello?
I can hear you clearly.
Wonderful. You can see my presentation?
Not yet. Please share.
Thank you very much, Chair. I am very pleased to be part of this webinar and to share with you the experience of Morocco in introducing the implant as a contraceptive method among the methods offered by the National Family Planning Program in the country. Let me first start by some background information about the program. It has been launched in 1966. And since this time, it has evolved over time and had reached a level of CPR of 71%. The unmet need is around 10%, and the participation of the private sector is around 50%. So the program has also a big impact on the fertility, since it has been reduced from 7 children per woman to 2.4. Unfortunately, the method mix is dominated by the pills as a short-acting method. This is why the objective of this main intervention was to promote the use of long-acting method to balance the current pill-dominated contraceptive method. In terms of implementation strategy, it is based on 3 key pillars: the adoption of an experimental approach through a pilot project of 3 years, which has been evaluated at the end of 2016, and also the adoption of a training strategy adapted to the national context within the decentralization framework and targeting medical doctors. Another pillar is the establishment of strategic partnerships with key players, especially the UNFP as development partners, the health region as a decentralized entity in the country, and the Faculty of Medicine, and of course, the national level through the Family Planning Department within the Ministry of Health. Monitoring and evaluation was part really of the implementation process. It has adopted 2 approaches: quantitative approach based on individual forms and summary reports and databases, and qualitative approach based on interview and focus group with user and providers. In terms of direct effect of the intervention, what we are seeing right now, that the current user of implant are coming from the pills, which is really good, and it's promising that we are going to balance really the contraceptive mode in favor of long-acting method. Another indicator is that the 2 years continuation rate is very high, more than 80% of the women really, they are coping with the method more than 2 years. And also we can see that really the access to the method is evolving in parallel with the extension of the method to other regions of Morocco. In terms of replication and transferability, the model of the pilot project has been successfully replicated to other regions in the country, and it also has been at the international level shared within a meeting held in Tunisia in 2017 under the flagship of the UNFP, where the experience has been shared with other countries. In terms of lesson learned, we can say that the introduction of a new contraceptive method among the range of methods offered by a program requires institutional support. You need institutional support really to introduce a new method. You need also strategic partnership with local stakeholders, including development partner and critical implementation initiative. You need also, in terms of introducing a new method, that it should be evidence-based. Hence the importance of a pilot project before any expansion or generalization. And also the existence of a decentralized system, reduce effort, cost, and strengthen local leadership for program implementation and development. I have some recommendations. So part of them are for program implementation and development, and this is for our colleague in the Ministry of Health, that they should involve other profile in service delivery, such as midwives who competently perform ID insertion and deliveries, establish an agreement with the private sector to promote access to the method, and develop an advocacy strategy to include FP services within the health insurance scheme in the country. For South-South collaboration, the PPD Secretariat maybe need to facilitate increased communication between Morocco and the PPD countries through appropriate channels. And also, we need maybe to encourage the coordinator of PPD Morocco in activity, the PPD activity in Morocco, especially the board member and the PCC, to advocate for better integration of population development issue in collaboration project included between Morocco and other sub-Saharan African countries. Morocco is doing a lot of collaboration within Africa, and I think this is an opportunity to include some issue of population and reproductive health issue in those agreements. And thank you very much. I hope I was in time.
Okay. Thank you. Thank you, Mr. Abdullah, for a remarkable presentation. It is my pleasure now to hand over to Dr. Bancha Kakhong from Thailand to deliver the presentation, policy and arranging unsafe abortion prevention service under Universal Health Coverage Scheme. Dr. Kakhong, you may start your presentation now, please.
Yeah, thank you. Ladies and gentlemen, and my PPD partnership, good evening from Thailand. Thailand presents the safe abortion policy and arranging unsafe abortion prevention service under Universal Health Coverage Scheme. Okay, you will show my slide, please. Oh, thank you. Next. Okay. It is the model of development of safe abortion service in Thailand. At the first add-on, we introduce the hotline by the number 1663 and referral system for safe abortion service in Thailand. In the year 2014. The second model, we developed medical abortion in 2017. And the third is abortion by MPV in the year 2017 too. And the year later, we provision of long-acting reversible contraception after abortion. And on service and on product, we support by universal health coverage. Next, please. We have a first step of implementation. First step is we introduce medical abortion. Pilot study on abortion pill to healthcare service in Thailand during the year 2012 and 2013. We take efficacy of abortion bill is about 95%. We promote the registration of abortion pill to the FDA or Food and Drug Administration in Thailand in the year 2014. We encourage the inclusion of abortion pill to national list or the DAC, essential DAC list of Thailand at the year 2018. The second step is the health personnel. We develop the network of referral system for safe abortion. We have about 159 RSA doctor and 614 paramedical staff. We develop guidelines about the legal abortion service. Next slide, please. The third step is we introduce the service system development by the two organizations. The first is National Health Security Office, and the second is the Department of Health. We creating and improving the innovative training course on safe abortion in Thailand. The last step or the first step is Universal Health Coverage Scheme. The National Health Secretary Office offered on payment about the medical abortion, surgical abortion, payment about long-acting reversible contraception, and the IUD and the Norpen or implantation. Okay, next please. This is the graph of the success of exit abortion service in Thailand. By the year 2016, we have the case of abortion about 3,000. And by the 3 year, we increased the accessibility of abortion service to 23,000. And the year 2020, it decreased because of the lockdown from COVID-19. Next slide, please. And also, the birth rate of the women is from 15 to 19 years, decreased from 53.4 in the year 2011, decreased year by year to 31.3 in the year 2019. Next, please. And also, the total abortion in Thailand, it decreased from year to year, from the year that we take the medical pill and the referral system abortion to the Thailand service. Okay, the last one. Next slide, please. Is it the key success of safe abortion in Thailand? The first is the model development of abortion service by Department of Health. And the second is the payment mechanism by universal coverage that left no one behind. Okay, thank you. See you later.
Thank you, Dr. Bancha Kakong, for your stimulating presentation. Thank you also to everyone who has been submitting questions. Please keep the questions coming on the Slido link for the question and answer session. Continuing our session, I would like to invite Dr. Farouk bin Mansour from Tunisia to deliver his presentation titled Mobile Services Strategy for Family Planning and Maternal Health in Tunisia. Please join me in welcoming Dr. Farouk. Dr. Farouk.
Thank you. Thank you very much. Are you hearing me?
Yes, clearly.
Thank you. I have prepared my intervention in French. Is it possible to read in French?
Yes, possible, please.
You have asked me in the beginning to present my paper for 5 minutes, but then you have asked me, I think, for 3 minutes. I have reduced it to 3 minutes.
Okay. Okay.
What am I going to present? The first or the second version?
Okay, the first version. Okay, please.
Okay. La stratégie des services mobiles dans le programme tunisien de santé de la reproduction. Is there a translation?
Yes.
Thanks. Les motivations. Le recours à la planification familiale était un choix politique dicté par les mauvaises conditions socio-économiques du pays au cours des premières années qui ont suivi l'indépendance en 1956.
Tips that is based on the economic development in Tunisia. This is part of the global reformation to create a modern society. 5 years after our independence, and we banned polygamy, we include women in many roles, in many sectors.
Is there a problem?
Through our study in 2 months.
No, no problem. Keep talking.
Can you
It's
hear my
okay.
voice
We have a translate interpreter. No problem.
No, sir, you can continue. Thank you. As I mentioned before,
سفارو انزل على سفارو Unmute. And smoked. Ok, c'est bon, c'est bon. Ça marche.
Je disais que la mise en place du programme a
As I
commencé
mentioned before,
par une phase expérimentale dans 5 gouvernements.
the program of 1964, based on the experiment that we conducted,
Le programme a été intégré dans la santé maternelle et infantile.
the program has been incorporated
En 1973 a été créé
into the program for maternal and child health.
organisme autonome
And then we established a specific office for family planning. And we implement an autonomous strategy under the Department of Health of Tunisia.
des services était
The mobile strategy that we implement
pour contourner le manque de personnel médical
is an ideal solution
ainsi que le nombre limité des structures de santé, notamment
to
dans les
address
zones rurales
the lack
où vivait
of
plus que la moitié de la population.
jobs, especially in village
L'objectif
areas.
principal était de réduire la fécondité par le recours à la contraception
And this
préventive par ligature des trompes,
will reduce the total fertility rate through the use of contraceptions, whether the permanent or non-permanent contraceptives.
les activités de programme ainsi que les objectifs chiffrés étaient tracés au siège de l'Office national de
Under this program,
conformément aux différents plans nationaux de développement, tandis que la gestion des services sur le terrain
we classified under the national category
dans chaque gouvernorat, sous la coordination du premier responsable appelé délégué régional de l'Office et de
and the local workers will deal with the issues, and the midwives will support the provision of services. This mobile services strategy
une sage-femme
is implemented by
ou deux personnes
trained
paramédicales
expertise, such as the midwives
Ces unités
and
étaient de
also medical
Il y avait
assistants.
les équipes mobiles qui couvraient
The
les
services
centres de santé
is divided into 3 types. First is the
Il y
mobile
avait des
type.
cliniques mobiles qui étaient
Secondly,
en
at
charge
health
des
center.
zones rurales
And then we
des
also have a
pays
mobile
centres
clinic,
de santé
which
fixe.
provides services
Et il y avait les unités mobiles
at
d'éducation
the villages.
composées chacune de 2 éducatrices. Ces dernières empruntaient le même circuit que celui des unités mobiles
And the
de
staff
service. Un jour à l'avance, elles
providing the
faisaient le
services
porte-à-porte
will also
pour
support
créer
other
la
service
demande
units
et motiver les femmes
to
aux
carry out
consultations
door-to-door
médicales
services
qui auraient lieu le lendemain.
in order to
Des outils
increase the
de travail
participation of
standards
women
ont été mis
in the
à la
program.
disposition des prestataires de services, tels que le dossier médical et les
And the
documents
job
de
is
recueil
given
statistique.
to
Le programme est passé
the
par différentes
villagers, for
étapes
example,
de
including the
commencement,
administration of health records.
essentiellement en 5 phases.
And in the implementation of
Chacune
this strategy is
d'environ
divided
10 ans.
into several stages.
La première, le planning familial était
And
plutôt
in total,
considéré
it
comme
takes
une
10 years.
invitation à la
First
naissance.
is the family planning
La
program
deuxième, il y a une mutation vers le
in order to
concept de
reduce the
l'espacement
number
des
of
naissances.
birth rate.
La
Secondly
troisième,
is
c'est
the timing
l'intégration des services dans un cadre
between
plus large de santé familiale.
birth,
Au cours
and the third is the
par la
access
suite, le planning
to
familial cède sa place à une idée plus globale,
delivery
plus générale,
services.
la santé de la reproduction. Au cours de la dernière étape,
And we
une
also deal
importance
with reproductive
particulière
health
est
issues.
accordée à la santé des jeunes pour la lutte contre les IST et les conduites
And we
addictives
also
avec engagement
implement programs that attracts the adolescents so that they are more
après plus
interested
de 5
in
décennies. Les
participating in the
réalisations du
program.
programme sont hautement parlantes
Okay.
au regard de 3 données comparatives entre 1956 et 2020. Premièrement,
Through this implementation, we will have
de 3% à 0,86%.
strong data And we experience reduction of number of population, and the number of children reduced from 6 to 2 children, and life expectancy rate is becoming higher. Thank you for your kind attention.
Great presentation. Next, I try to calling back our speaker from Ghana. Mr. Kojo, are you in?
Yes.
Yes.
Good afternoon, Prof.
Yes. Unfortunately, sorry, Mr. Kojo, your voice is breaking.
Good afternoon, Prof. Can you hear me?
We can't hear you clearly, Mr. Kojo. Sorry to inform you. Please try to,
Good afternoon, Prof.
move to the good location. We can't hear you clearly, Mr. Kojo. I'm sorry for that.
I can hear you. Can you hear
let's move.
me?
Sorry? Mr. Kojo?
Hello?
Hello? Yeah, I can hear you, but the voice is breaking.
Prof. Raja.
Yes. I can hear you, but the voice is breaking.
Yeah.
It's not stable.
I can hear you. Can you hear me, Prof?
I can hear you, but the voice is breaking. It's not stable. Try to fix it, and then I will call you back later then. Okay, next I would like to invite Mr. Luong Guang Dang from Vietnam to deliver his presentation titled Population and Family Planning Program. Ladies and gentlemen, please welcome Mr. Wong. Mr. Wong, time is yours.
Thank you very much for the share. So, Tarima Khan, so you can help me for presentation?
Yeah, sure, we're sharing.
Okay, thank you. So, Vietnam is very good evening from Hanoi, Vietnam. Now it's nearly 10:30 p.m. from Hanoi, Vietnam. Vietnam is one of the first country in the world that is started for population and family planning since 1961. But this program is not successful for some decades. Until the 1992, the fertility in Vietnam was very high. TFR was around 3 and 4 children. The annual population growth rate was more than 2% per year. The maternal and child mortality was high, as the life expectancy at birth was low. The people in Vietnam had to face with many difficulties in the life of the poverty and the hunger. To face this issue, the government has dropped with the policy focused on the population and family planning. As luckily, in 2005, Vietnam achieved the replacement fertility rate and keep constant until now. The growth rate of the population reduced. So let's slide please, Tarima. The growth rate of population also reduced with the maternal mortality and IMR and the family mortality also reduced, and CPR also increasing, life expectancy also increasing. So the life expectancy also increasing. So please the next slide. So you can see in here with the TFR in Vietnam, it keeps constant for more than 10 years ago. So the success of the reduced fertility in Vietnam, that brought Vietnam enters the different population periods with a huge number of the people as working age in 2007. It was advantage for socio-economic program in Vietnam, improving the people health, improving the education status, improving the gender-based equality issue, and increasing GDP, and improving the quality of life of the people in Vietnam. So what is what is made for the Vietnam success in the population and family planning? That is, we can find out that is that is 8 lesson. First is the policy must closely link with the social and economic policy, the constant with the aspiration of the majority of the people. The secondly is a strong political commitment, and the third, that is the organization from the central to local level. And the fourth, that is the network of the population and family planning, the cooperation motivator development in whole the country. And the five is the investment for the population and family planning program. The sixth integrates the IEC and productive health service, ensures the convenience, safety and for the efficient for the user. And the second is training, research, and program management. The last is the international cooperation is expanding. However, at the moment, the Vietnam's population program also has to face with some news is challenge, such as with aging issue and low fertility in some region, or the imbalance sectoral effort, and the government also drops the new policies that focus on the population and development in that the integrates the population factor with another social and economic program. Next slide, please. The finance sentence, I would like to thank you so much with my team colleagues, that is Dr. Bùi Minh Tiến from the Thái Bình University Medicine and Pharmacy, Mr. Phương Thị Thu Hương from the Central Population Study Information and Database of the GOPP MOH, Dr. Mike, officer of GOPP Ministry of Health of Vietnam. I also thank you the Executive Director of PPD. Thank you the Tarima Khan and her colleagues and UNFPA for selecting Vietnam. Thank you so much.
Thank you, Mr. Luong Quang Dang, for your stimulating presentation.
Thank you.
Ladies and gentlemen, now it's my pleasure to hand over to Professor Joshua Campbell as today's discussion. Professor Joshua is an epidemiologist and demographer from South Africa and PPD consultant for best practices. Professor Joshua, we are so glad you could be here today to share your insights on those best practices on reproductive health and family planning shared by 10 presenters. Ladies and gentlemen, please join me in welcoming Professor Joshua Campbell. Professor Joshua Campbell.
I would want to thank you, Chair, and thank you very much, Your Excellencies, ladies and gentlemen. I want to thank you for this opportunity for me to provide a commentary on the 11 best practice reports. I've read through all of them. I've consolidated them. I've worked through them. I have synchronized them as well, just to have a more standard approach and standard structure. And I should say that they are all unique in their regards. They add to the objectives of PPD, and they are all well written. They are all in support of the South-South cooperation in terms of family planning, reproductive health, population and development. And in a way, they are also unique in their contribution Initially, their quality was varied as one would expect, because these are different writers that are writing in their own style and describing their own experience. But having said that on quality, I'll be quick also to say that we had a quality that we were looking for, and we were able to work through them to up the quality and standards so that we can end up with the consolidated best practice reports that we now have out of the 11 country reports. So, Chair, without lengthening it and having said that, I will now ask I'll ask Dr. Islam to share the slides that I have so I can walk through them. Dr. Islam, sir? Are you able to do that, Dr. Islam? Thank you. Thank you very much. If you can move to the first slide without much ado, the very first one. The very first one, sir. Yes, thank you very much. I would want to highlight that the 11 best practice reports that we have had today, it is a little bit unfortunate that we have missed a few because of connectivity, but suffice to say we have heard from most of them. And I've also given in my introductory remarks, I have also given a short commentary about them in terms of their quality, in terms of their presentation, and also I've emphasized really that they add to the objective and goal of PPD in a unique way, and they are all valuable in their 11 awesome. And they should be able to facilitate the best practice sharing, South cooperation through exchange of experiences, through lessons learned, and also through technical expertise as well. And as I said, also that they address issues on reproductive health, population and development, and also family planning as well. Next slide, Sam. Now, I will highlight some unique aspects on the case studies. We know that they have been presented already, so I won't bore you with much details. We have heard about it, but I will synergize. I will tear through them to be able to synchronize what is coming out of these country reports. And I'll also focus more on replication, because when we speak about the possibility for South-South exchange, South-South cooperation, we're also interested in the replicability of the experiences which is coming out. So the best practice report, which is coming out of Bangladesh on maternal deaths, free Kapashia model. This is a model that they have described this afternoon to us. The main prerequisites for replication in other developing countries is to have a field level human resource. That's the main thing, that you must have a robust field level resource to be able to introduce the model. Next slide, sir. If I move to China, where we see the maternal care service during COVID-19 in China and around the world, this model, the main take-home replication for other developing countries is that there should be a fast communication system and also a comprehensive network of maternal and child health services that should be able to be supportive, and also a well-run community organization as well as community buy-in. Next slide, Sam. If I move to Egypt, where we have got the Ayama Allah initiative, this is a reproductive health model. We see that replication can be achieved by collaborating with the national organizations and partners who are familiar with target groups and local conditions. Next slide. If we move to the Gambia, we see Gambia also contributing in a unique way to this wholesome experience, whereby this Kahab Bama Male Action Group project requires stable and peaceful countries, a stable and peaceful setting, and also the use of statistics and community profiles to be able to identify the communities in need. Next slide. If we move to Ghana, and we focus on the adolescent reproductive health projects in Ghana, replication will require strong institutional collaboration and sustainability planning. Next slide. In Kenya, the aspects related to replication in the Engaged toolkit, this is an interesting initiative, the Engage. Requires technology, requires data sharing, but we see that if Engage is to be replicated within the South-South cooperation, there will be need to facilitate capacity for population health and environment issues, especially the environment part is quite lacking. We have so much on population and health, we could have so much, but there will be need to make sure that the environmental aspects are also brought in line as well. So there is special need for capacity. And this capacity could come in, for instance, training of other countries or training in other countries within the South-South cooperation to facilitate replication. But also lastly, to suggest that Kenya could, for instance, provide scholarships to other countries within the South-South cooperation to support replication for the Engage toolkit as a replicated program or project. Thank you. Next slide. If we move to Morocco, we have had the presentation this afternoon. Political support for the initiative will be a major input if it is to be replicated as well. Next slide. If we move to Vietnam, we see this is a family planning model, family planning program whose aim was to ensure the achievement of small family sizes among the population, small family sizes. But again, what we are learning or what we are hearing of from this project is that it will be important if it is replicated to ensure that there is participatory approaches which also encompass a human rights-based approach as well. Because we're talking about targeting small family sizes. It may not be desirable to all the population segments. So again, in order to ensure buy-in, in order to ensure the ethics and integrity of the whole program, there will be need for participatory approaches, but it will be, and it will need to be done in a human rights-based approach as well. Next slide. If we move to Kenya, we also learn that this is an interesting program, again, around FP, and we will see that it has witnessed an evolution from so much focus on population control to focus on, desirably, on improving maternal and child health outcomes, which is something that we are taking off from here as well, that it may be not so much about the focus on population control, which may tease out community opposition, for instance, which may hinder or which may hinge on human rights-based approaches. But if we come with targeted improvements in, for instance, maternal and child health outcomes, we may have more desirable end results and more desirable outcomes as well. And here we emphasize that human rights-based approaches would be central as well. But I also add that leaving no one behind as well, so that no one is left behind, especially the vulnerable groups will be able to be brought to the fore as well. Thank you. Next slide. Here, Chair, what I've done is to pull all these aspects that we have been discussing as I was walking through the individual case studies. We have now pulled those issues into a more generic structure. And we're now saying, what are the key observations which we are teasing out from all the 11, the commonalities which we are teasing out from all the 11 case studies, so that we can use them to promote South-South cooperation. We start with stable and peaceful countries. This is peace. Stability and peace is a major ingredient for replicability. And for a good functioning South-South cooperation, there will need to be peace and stability among the countries. Again, community participation and participatory approaches are key as well. And consultation, wide consultation would be key. Technological divide, again, especially in these times of COVID and beyond, technology has come to the fore now. But then besides that, there is different capacities among the countries in terms of technology as well. So what are we talking about? We are talking about bridging the gap in technology. Not only promoting it, but bridging the gap, particularly within the South-South cooperation, within the countries in the South, to have a more similar approach in terms of technology so that we can bridge this divide. And we believe that this will be able to promote the replication within the South-South cooperation as well. And we spoke about leaving no one behind, targeting the most vulnerable of our vulnerable groups within the community. And that will be key as well. We spoke about it earlier on, and we spoke so much also about making sure that at the center of replicability, at the center of implementation within the South-South cooperation, and I'll speak about implementation as well later on. But for now, to say the human rights-based approaches should be central so that everything is guided within the integrity and within the ethics of the program as well. And I'll speak last now on, besides human rights-based approaches, I'll speak about implementation to say that so many best practices have been compiled. So many documents have been compiled. I think PPD alone, since 2011, I think up to now, I was just doing a count the other day, up to 36, nearly 40 best practice or practices have been accounted for, have been documented. My question to this conference today, to this important conference, is what do we do after this? What do we do after all this evidence that has been shared and discussed and paraded before us? I'm happy that in this conference, we have got the political powers that be. We have got the minister or ministers attending. We have got the high-level expertise professionals within this meeting, within this conference. And I want to address you now to say, what do we do after today? Do we wait to come back again and then say, we were discussing, we were sharing the 11 best practice reports? Do we do that? Or we should be able to talk about how do we implement and make sure that after a year, after 2 years, we can look back and say, on that day that we discussed the best practice reports and we discussed the issues for replication, we discussed about South-South cooperation, and I'll even add to say, lastly, South-South cooperation itself should cease to remain a buzzword. It should cease. We have heard about it so many times now that these are buzzwords. Talk about leaving no one behind. They'll say these are buzzwords. Talk about the human development nexus. They'll say these are buzzwords. Talk about South-South. It's time it ceases. It's time we take the evidence and be able to inform implementation, because this is a very good research evidence that has been produced by the experts from these 11 countries. And we have now consolidated all these 11 best practice reports into a compendium document, a consolidated document with a summary, with an introduction, which addresses each one of them, which summarizes each one of them. You can also read the details in each of the reports as well. But I'll end by pleading to say it's time we really think about and talk seriously about implementation itself, and also financial commitment as well, because implementation will also need the commitment financially as well. And it's time that the countries also should gear up and should commit more so that we can implement most of these initiatives which have been discussed and described for sharing in these 11 best country studies. Thank you very much. Over to
Thank
you,
you.
Chair. Thank you.
Thank you. Thank you very much, Professor Joshua, for giving such insightful and comprehensive views on reproductive health and family planning best practices. And also your stimulating question, what's next? Thank you very, very much for it. So, Excellencies, ladies and gentlemen, I would like to thank you again to all speakers for your stimulating and very interesting presentation. And it was a pleasure to have you with us. This is the end of presentation. And thank you again. I will give the floor back to the host, Ms. Tahima Khan. The floor is yours. Thank you.
Thank you, Honorable Moderator. And here I would like to announce, due to time constraint, we need to make all the discussion and question and answer session. And but we'll try our best to answer all those questions later to be made. Now I would like to call for the closing remark, Ms. Chowa Dasoki, Director of Population Policy, League of Arab States. Ms. Dasoki, the floor is yours now.
Hi, hello. Hi, good evening. Good morning and good afternoon for everybody. Your Excellency, Mrs. Lindiwe Zulu, Minister of Social Development in South Africa and Honorable Chair of PPD, Professor Rizal Damanik, on behalf of His Excellency, Dr. Hastu Bordowo, Honorable Treasurer of PPD, Mr. Adnan Ben Haja Isa, Executive Director of PPD, Mr. Arthur Erkin, Director of Policy and Strategy at UNFPA, distinguished members of PPD, respectable consultants and speakers, experts, civil societies, ladies and gentlemen. Thank you very much for the invitation to join you today and participate in this webinar. It gives me great pleasure to speak on behalf of the League of Arab States as the Director of the Population Policies Department, which is also the Technical Secretariat of the Arab Council for Population and Development. Since 1994, the League of Arab States Population Policies Department has considered the ICPD Program of Action a steering document that lays out all its activities and has worked closely with MPCs and committees in Arab countries to achieve significant progress in implementing the ICPD Program of Action. One of last main achievement in this regard is finally the establishment of the Arab Council for Population and Development in 2019, affiliated to the Economic and Social Council of the League of Arab States, to form an Arab cover that embraces the national councils and committees of the population in the Arab countries and follows the implementation of the ICPD Program of Action and the Cairo Declaration 2013 and related SDGs. It was launched in Amman, Jordan, under the patronage of Her Royal Highness Princess Basma bint Talal with the support of UNFPA Astro Office. The ACPD main objectives are to institutionalize joint Arab action on population field, promote the integration of population issues and dynamics as a primordial factor in policies, strategies, and action plans on the national and regional level, and raising awareness about population issues in Arab countries at all governmental and non-governmental levels. Based on the convergences between the objectives and priorities of the ACPD and the PPD, we have signed a memorandum of understanding in 2020 to enhance the cooperation in the field of population and development. And as it's known, the ICPD Program of Action and Cairo Declaration emphasized the importance of providing sexual and reproductive health services for all and putting an end to harmful practices. To this end, we have deployed many efforts to stress on the importance of the reproductive health and family planning on the Arab regional level. Despite the remarkable achievement in this field in our region, the COVID-19 pandemic has surprised the entire world with an unusual speed of spread and unexpected damage at various levels. In that vein, and in light of the last efforts to confront the social repercussions of the pandemic on different population categories in the Arab countries, allow me to brief you on some of the key messages, statements, and recommendations issued by the ACPD during some of the meetings that we organized in 2020 and in relevance to the reproductive health and family planning. In order to face the consequences and repercussions of the COVID-19 pandemic on the population sector, the ACPD call on the official institutions concerned to follow up the current repercussions by working on strengthening partnership with UN agencies to ensure universal access to reproductive health services, especially emergency services in humanitarian situations. Calling the governments of Arab countries to give priority during this critical stage of the sexual and reproductive health of women and girls during their COVID-19 response. Emphasizing on basic population issues and the necessity not to lose sight of any of them in the context of crisis, especially sexual and reproductive health issues and gender-based violence. Ensuring adequate provision of modern family planning methods, maternal and newborn health supplies, including emergency reproductive health kits in humanitarian situations. Highlighting the necessity of financing family planning centers, working to provide reproductive health services while supporting them with modern technologies, especially remote examinations, which can contribute to avoiding infections at the level of public institutions. Ladies and gentlemen, signing the agreement with PPD, especially in these difficult and unprecedented circumstances, opens new horizons for our member states in the light of South-South cooperation to open up to other experiences and expertise and benefit from them. We also hope to open ways of partnership and cooperation with other organizations and countries that enrich our experience. All topics and activities that fall within the framework of the ICPD Program of Action and Cairo Declaration 2013 and related SDGs may be the subject of discussion for cooperation between our two organizations. In this regard, it's important to highlight our action plan for this current year, 2021, which will be implemented in partnership with UNFPA ASRO. We are about to finalize an Arab strategy for population planning that takes into consideration the demographic diversity and political, economic, and social challenges taking place in the Arab region. We'll hold workshops to share best practices and successful technical experiences for ACPD member states. These workshops could also be done in cooperation with the PPD member states to benefit from their success in the field of population policies application. We'll organize an expert group meeting followed by a study on the impact of COVID-19 on harnessing the demographic dividend. Also, we'll hold workshops for capacity building for the ACPD members. We'll hold workshops for ACPD members on developing crisis response plans, as well as good preparedness for crisis and emergency population situation. We'll develop a regional study to analyze the epidemiological situation and its impact on the population in Arab countries. And finally, we'll organize a side event on the margins of the 54th session of the CPD about population, food security, nutrition, and sustainable development. Finally, I hope that this agreement gives the chance to explore ways and means of cooperation between LAS and PPD, to share good experiences, supporting populations and development issues, as well as promoting interregional cooperation. Thank you very much.
Thank you very much, Ms. Jawad Dasoki, for your very nice presentation and also highlighting the partnership between Arab League and PPD. We also looking for a very future, very good partnership and strengthen this also cooperation together as well. So now we are very close to the program, and I would like to call Mr. Wiki Kusuma, the head of Center for International Training and Collaboration of BKKBN, for giving some recapping remarks for this today's session.
Thank you, Ms. Tahrima Khan, for the opportunity. Good evening from Jakarta. Excellencies, ladies and gentlemen, my name is Uki Kusuma Kurniawan. I am the head of Center for International Training and Collaboration, BKKBN of Indonesia. I would like to thank all the wonderful guests who perform on this webinar as speaker, discussion, as well as the moderator by the Excellency Professor Rizal Martua Damanik, PhD, for a very interesting and fruitful discussion on the topic. I might not have further conclusion, as this is very clear and straightforward. I also would like to convey my greatest respect to all participants for your positive insights in the webinar. I hope that what we have learned today through this webinar will help us in strengthening the population, family planning, and family development program on the spirit of South-South collaboration. I also must thank Executive Director PPD, Mr. Adnan Ben Haj Aisha, for collaborating with BKKBN on conducting this webinar. Dear distinguished guests, colleagues, and friends, as our appreciation for your participation, please obtain your certificate by filling the link of the Google form. You will receive your certificate written on your name automatically after completing the form. Finally, on behalf of BKKBN, I would like to express my appreciation for your valuable contributions and also officially announce the adjournment of the webinar. And we hope to see you again in our future event. Stay safe and thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Thank you, okay? Thank you very much.
Thank you.
Thank you all. Thank you, Mr.
Thank you, everyone.
Statement. Thank you very much for the participation. And I thank all the participants. I thank all the presenters. Thank all colleagues, friends for being with us today. It was too long, sorry. And but I hope the webinar is very productive. Thank you very much.
Thank you,
and stay
Adnan.
safe.
Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.
Thank you very much, everyone, for your patience and to participation in this webinar. Thank you very much.
Bye.
Thank you. Thank you.